Maybe I'll just start with that presentation. How should we be thinking about the ciliary function that we're seeing or we think may be impaired in these children with heterotaxy? Is there something we can learn from kind of work you're doing?
I think so. I think a better knowledge. Oh, yeah. Okay, great. I think with a better knowledge of the genes and the proteins involved in generating motility across different types of cilia, that will help improve the genetic diagnosis. It will make the genetic analysis easier. We'll know which genes to look at when we have patients with, heterotaxy with maybe ciliary dysfunction or recurrent respiratory disease. And so I think there is a link between what we're doing and better analysis and diagnosis of the patients with heterotaxy.
Yeah, I think cryo-EM is regular EM on steroids. It's just hard to get from a clinical standpoint. We will commonly have patients with partial outer dining arm absence. It's shortened in, 50%. It's not there in 50%, but there's certain cross-sections that are normal, and the genes will show one variant in DNAH5, but we don't have the second variant. And cryo-EM could be a wonderful diagnostic tool if we could find a way to kind of speed it up and get it diagnostically. Right now it's a lab tool, but it could easily show you're actually missing 3/4 of your dining arm proteins, and it could be used diagnostically.
But I would say I think we're many, many years away from it being a clinical tool.
Oh, yes.
Question?
Hi, thank you for a series of just fantastic talks. My question is for Dr. Lowe. And you mentioned the type 2 heterotaxy genes that always cause heterotaxy in animal models, and one of them was MMP21. Where is that gene expressed? Is that a ciliary gene, or is this one thing I'm interested in is how the downstream things post-nodal events occur? Is that what's going on with the extracellular matrix or what?
Yeah, as you know, MMP21 is a metalloprotease, right? So it's involved in remodeling the matrix. It is expressed in the node, but whether the function is strictly just in the node or how signals transmitted from the node to the lateral plate mesoderm, for example, it's not known. So not much work has been done on it. We have not really pursued it. There was a group in Jackson Labs that were trying to do some work on it, but I think that I don't know where it is with that. So sorry, I don't have more insight.
That's okay, thank you.
Okay, hi. So I have about 10 questions, but I'm going to choose one. All right, so here's the thing. The diagnostic tools we have been using in clinical practice for 15 years for PCD really just aren't going to work for heterotaxy-associated ciliary dysfunction, if that truly exists, okay? But is there a possibility that some of those tools might have value, like nitric oxide, for example? We saw in many of those studies, nitric oxide levels in heterotaxy patients are not PCD level, but they're not normal either. Is there any value in saying that nitric oxide can have a quantitative assessment of how the cilia actually function, or is it black or white? It's either normal nitric oxide or not normal nitric oxide.
I can start. I mean, we all want a yes or a no, and we're not going to get that here, short of mucociliary clearance testing, and even that might not give us yes or no. I think longitudinal data is what's missing, right? No, we haven't taken these kids with heterotaxy and done nasal NO on them 4 times a year for 2 years or 4 years or 5 years to see where it goes. And I think that would be very interesting because it's a crude tool. It can be influenced by so many different things. So I think that's the first thing. We need longitudinally to show what happens over time with it. All of the other things are great when they're positive and they're hard when they're negative. And so this is why I really think mucociliary clearance scanning could, one, tell us if it's real or not, if it's done in a lab that knows how to do it. And then two, it can be done clinically. You could have a network of mucociliary clearance tests and you could piggyback on top of cystic fibrosis centers that know how to do it and actually test these patients. And it might take a test twice, you know, to make, when you're sure they don't have a virus and you're sure they haven't recently had surgery and things like that. But to me, that's going to be the ultimate goal in showing which patients have ciliary dysfunction or not. And then you got to correlate that with clinical outcomes. Are these the kids having more pneumonias? Because the problem is these patients are just so complex. It gets hard for me to blame everything on cilia when we all know there's so much going on in these kids. And we haven't even gotten to the immunodeficiency part and the heart part yet, which is coming in the upcoming sessions.
So, yeah, so I just want to comment that we have actually followed some of these heterotaxy patients and done multiple NO measurements, because in Children's Hospital of Pittsburgh, patients come back. So there's very good long-term demographics. And so we do see that the low NO stays as low NO even as they grow older. I can't say that we've done it with all patients, but a small number of patients we have done multiple measurements. So I believe that low NO is real and could be diagnostic. But also regarding the mucociliary clearance scan, I think that's a wonderful tool, but I'm not 100% sold that that's really going to help us in all cases, only because we know heterotaxy patients generally don't have a lot of respiratory problems outside of having undergone their congenital cardiac surgeries. It's really during the cardiac surgeries that all these problems surface in an intense way that's actually clinically important. And what I'm saying is that I think that they have abnormal cilia that's very sensitive to the detrimental effects of cardiopulmonary bypass, a very low temperature, the anesthesia. So if you just do a mucociliary clearance scan on a heterotaxy patient outside of these surgical conditions, I'm not convinced that you're going to see very dramatic change in airway clearance. I could be wrong, and there could be a subset where you will see that. But the thing is that we know that most of these heterotaxy patients don't have severe respiratory problems or even otitis media. I mean, some of them do, but many of them don't. So I think that the abnormal cilia is making some change that makes them very susceptible, maybe the lower temperature. And I guess this is something that Alan could comment on, right? So co-sensitive mutations, change the folding of proteins, so that it could be that in some of these kids, they have mutations that change the cilia in some way that you can detect it in terms of motion, but that when you bring it to low temperature, they just might not move. So I just want to say that I think that the mucoclearance scan is wonderful. It's very quantitative, but I don't know that it will help identify every patient that actually might be suffering abnormal motion that could actually be a problem in terms of their respiratory outcome.
And I 100% agree with you. I think it'll be the tip of the iceberg. I think one day we'll have forms of primary ciliary dyskinesia that are actually due to ciliary repair issues. You're fine till you get hit with the right organism, and then you can't repair them. We're just not smart enough to see that yet. But I 100% agree with you on that.
One assay that hasn't been discussed is the ciliary transport assay, where you take your nasal scrape, you grow the organoids, and then you add like fluorescently labeled beads and watch the transport of those. And there's some people in the field, like Hema or Ram, who believe that this is a lot more sensitive than the high-speed video microscopy, and is picking out mutations that were considered normal in the high-speed video microscopy. So that's another clinical tool that could be useful.
It should be said, we're just starting to recognize atypical forms of PCD that, for instance, do not affect the ears. Hyman Omran's group published a small group, probably 10 patients with new central apparatus gene defects that basically did not have any ear disease. So we don't know the whole phenotype. We're scratching at the tip of the iceberg.
Yes, please.
Sorry, I hope it's not too forward. So I'm going to ask my simple country cardiologist a question here. So if I'm understanding, there's a pretty decent amount of overlap in terms of the genetic underpinnings of congenital heart disease with heterotaxy and congenital heart disease without heterotaxy. From what I understand, there's a relatively substantial proportion of patients with congenital heart disease, non-heterotaxy, that have abnormal cilia function tests, however you want to assess that. So my question is, are we, maybe in the cardiology realm anyway, underappreciating the connection between cilia and congenital heart disease in general? And should we be looking for cilia dysfunction more broadly among our patients with congenital heart disease?
So David, I agree with you completely. And actually, some of the studies that I presented really were studies of all congenital disease patients. And the paper we published, Andrea Garrard is the first author. We included, it's like maybe 400 patients that were ones with and without heterotaxy. And so it was the second paper we were publishing. The first one was just all heterotaxy. And the reviewers made us take out all of the heterotaxy patients. And so that paper is really almost entirely non-heterotaxy, several hundred. And so ciliary dysfunction is actually quite prevalent in non-heterotaxy congenital disease patients. And so I also want to refer to the mouse work that we did. You know, we did this large-scale screen looking for genes causing congenital heart disease. And we recovered over 100 genes that cause congenital heart disease. And surprisingly, over 60% of them are cilia-related. Now, they're not all multicilia genes, but I would say maybe around 20%, 30% were multicilia related. So cilia perturbation is very central, I believe, to congenital heart disease, some of which, of course, will affect multicilia function that could affect the airway.
I agree with that as well. I mean, we see commonly heart defects in people with a known ciliopathy, PCD, that do not meet a cardiologist criteria for PCD. And we see kids with normal hearts. And so we have struggled with publishing. Back in 2014, when we were putting our big chest paper in on different laterality defects around that happen in PCD, that's why we couldn't use the term heterotaxy. They made a change it to situs ambiguous because they disagreed so wholeheartedly with our assertion that heart disease was related to cilia in all cases. And even when you have a known ciliopathy with a genetic diagnosis and you have a kid with tetralogy of Fallot, which no self-respecting cardiologist is going to call a cardiac ciliopathy, they had it. And so did it just creep in? Maybe. Or was it related to the cilia? We had VSDs. We had small ASDs. We had all sorts of things that would not fit the definition of heterotaxy. It's one thing this group has really done well. In the nice review paper that came out in the OrphanNet journal, we just defined it all as heterotaxy, and we're not calling it different things to leave people out. And I think that's really, really important. And I think they all can have a degree of cilia dysfunction throughout the body. The other thing is, you know, motile cilia and non-motile cilia overlap. Motile cilia can sense, and non-motile cilia can do, in certain cases, things that are more prone to motile cilia. So I don't think we really understand the whole spectrum of disorders that can come from a motile versus a non-motile ciliopathy. We've seen large amounts of bronchiectasis in patients with autosomal dominant polycystic kidney disease, which is a non-motile ciliopathy. Yet when you look on the respiratory cilia, the AD, PKD1 and PKD2 channels are there. They're on respiratory cilia. So there's an overlap we can't even begin to understand.
So how should we think about screening these patients? Is there a clinical way to start thinking about screening?
Yeah, I actually want to make a quick
Oh,
comment
sorry.
before we go
Yes.
into that.
Yeah.
There is a lab in University of Washington in St. Louis, or WashU in St. Louis, where they have actually collected a lot of evidence that suggests that primary cilia can be motile. And so they've done a lot of video microscopy in vivo as well as in vitro with cultured cells, and also show the expression of many of these genes associated with motile cilia in cells that are not associated with motility. And we've actually seen data like that in our own RNA-seq data over the years, and we just assume it's noise. So we've seen DNH5, for example, in the heart, and you don't expect that it's really going to be doing anything. But the long story short is that you wonder whether, in fact, there's a lot of overlap between cilia and between motile cilia and non-motile cilia in terms of function. And anyway, this lab in WashU suggests that motile cilia plays an important role in insulin signaling in the pancreas. She's an endocrinologist. but she's collected data like that for all kinds of tissues and cell types. So she had a paper that was, I think, published in Science Advances, and it was a PNAS paper. But I think this is an evolving story, and I know it's very controversial, but I just wanted to bring that up so that people are aware of this literature.
Said better than I could. That's what I was trying to say.
Well, maybe we should, oh, we have one more question.
One more question. Your mucociliary clearance test, can that be done in newborns?
I imagine you could. The problem would be normal controls. So you have to have healthy controls in the lab, and I don't think any researcher has healthy controls for newborns. We've got them for older children, mainly adults too, but yeah, I don't think so.
Yeah, we've actually done them in newborns, but not, we don't have controls. Like you said, we don't have controls. But we've done it on patients that are undergoing congenital cardiac surgery. And of course, you see that very severe depression of airway clearance, as you would expect. But we don't have controls, and that is a problem.
Obviously, anytime you go to the OR, especially with a complex heterotaxy patient, you instrument that patient. And you're probably going to screw up every possible study
Yes.
wall on presenting.
Yes.
On the other hand, what we really need to know, coming from just being the cardiologist in the ICU perspective, is we need to know if patients, when they come back from the OR, we need to get more excited about it. And so our testing modalities are pretty limited. And when you presented that, I was like, whoa, this could be big that we talked
So-
before.
So Tina, I mean, the thing is, you can do these scans pre-op, right? So we've done pre-op and post-op scans. And what you see pre-op can tell you a lot about what you might predict post-op. When you do post-op scans, what we found within the first 24 to 48 hours, nobody has airway clearance, okay? So we were quite shocked by that, absolutely zero. Right. So which is just what you would have, I guess we should have expected that, but it's nice to see it quantitatively.
Very nice.
So, but pre-op is, I think, the way to go, and that may give you some idea to predict how the patients would, what kind of care they're going to need post-op that could come from airway clearance issues.
From a practical perspective, what we need to find is testing modalities that we can turn over in 0 to 5 days
Yeah.
postnatally, and that will give us some predictive information on who needs to be
Yeah.
done and how. Because if you think about it, the worst thing you can do for a PCD patient is stick a tube down their
Yes.
throat. Because they can't, their only method of airway clearance.
Right now, it's a rapid genome. That's what you got. And the ones that are positive will help, and the ones that are negative, I think it brings up a larger point. The lungs get neglected. I have a kid in my ICU right now with a double outlet right that is misbehaving. He's been intubated for 2 months. He's not doing well. He had a whole genome or whole exome done prenatally on an amnio. I have no idea if they really looked for all the PCD genes on that. I've now resent a PCD gene panel to start just to see if I can pick something up. He's growing Pseudomonas and Stenotrophomonas in his airways, which is highly suspect for PCD. He is, every time they go down on his airway clearance and stop the hypertonic saline because a new ICU doc comes off, he crashes and was re-intubated. My colleagues in pulmonary are saying it's all due to his tracheobronchomalacia, which every kid has when you stick a scope in. And it's not a pancake malacia like I can't see. It's winking at me a little. And I'm telling these junior colleagues, I think you're full of BS. I think this kid has PCD or respiratory cilia dysfunction. And I've basically said to the ICU, if you ever go to less than BID hypertonic and chest PT, I am going to come up here and explode on you. Do not do it. This kid is leaving with a clinical diagnosis of PCD, and if I'm wrong, we'll know when he's 5 and has never had an ear infection and isn't coughing on a daily basis, and that's it. I think we need to put our foot down and be like, airway clearance is good in every case. Cecilia just said that. They don't have clearance post-op, and just do the damn airway clearance and treat with antibiotics more aggressively and culture the mucus every now and then to see what's growing. Treat them as presumed PCD, and outcomes will be better for everyone. This is how I approach it.
With regards to that, we've been a little bit more proactive in trying to identify these patients when they come in pre-op and getting also, so we send the genetics at the same time that we do ciliary ultrastructure testing. And those come back relatively quickly, especially if you push the pathologist, like, I need this. And I think, although I think we could treat everyone with better airway clearance, I think it convinces everyone of the need of using airway clearance and the adherence from the medical standpoint once you have a diagnosis. So we have been seeing, as pulmonologists, we've been very busy seeing these kids in the cardiology units.
Yeah, I really would like to echo and support what Adam said about, you know, with the MCC scan, you get the results the same day. So there's really no lag time. And it's non-invasive. You can load the radioactivity in a non-invasive manner. So you'll get the answer very quickly. I mean, the only drawback, of course, as I said before, you don't know in case if it's normal whether you won't still have a problem because, as I said, it could be a reaction to the anesthesia or the you know the cold temperature or whatever. So, but still, it's the least invasive. It's completely non-invasive. It's quick. You get the answer the same day. If you do see that there's a problem with mucociliary clearance from that test, then you know what to do. I mean, if it's a negative, you still don't know. But at least it's a quick and simple test that I think should be engaged.
I'm sorry to break, just to stay on schedule, we're going to give everyone a break. If you guys want to stay here for a little bit, if there are more questions, and they should reconvene at 1 o'clock. Great, well, thank you very much.